Dear colleagues, dear friends, it is my great pleasure to welcome you to today's IICH educational webinar entitled Periodontal Disease Explained, Classification, Treatment, and Hematologic Patient Care. I'm Mohamed Moti from the Sorbonne University and Saint-Antoine Hospital in Paris, in France. And I can assure you that this webinar is quite unique because oral health is often an underestimated but critical component of comprehensive patient management in hematology. Periodontal disease not only represent a prevalent and complex condition in the general population, but it also actually carries special implications for our patient with hematologic malignancies, especially those undergoing stem cell transplantation or receiving immunosuppressive therapy. Therefore, understanding its classification, pathophysiology, but also the treatment strategies, all of this is essential to providing safe, holistic, and patient-centered care. Today, we are honored to have with us Dr. Johan Sergert, I hope I'm pronouncing it correctly, who is an expert in the field. He is from the University Hospital of Reims in France, and I'm sure you heard about Reims. This is the capital of Champagne. So he is a top expert in this field, and he will guide us through this important topic. He will clarify how modern classifications of periodontal disease align with current treatment strategies, and most importantly, how these insights should be integrated into the daily practice of hematologists and transplant physicians caring for immunosuppressed patients. On behalf of the International Academy for Clinical Hematology, I warmly thank Dr. Sergert for sharing his expertise and all of you for joining us today. I invite you to stay engaged, ask your questions, and take full advantage of this live interactive session. Let us now begin this journey into the interface between periodontal health and hematology. Johan, the floor is yours.
Thank you, Professor Moti, for this kind introduction, and thank you for all of you to be present today. As it has been mentioned, today we will treat about periodontal diseases and we'll go through this classification, the treatment, and what is more interestingly for you, the hematologic treatment care and the implication with periodontal diseases. So I have no conflict of interest. And just to start, and maybe it can make you laugh, but for me it's very important to start with it, is that in human body there is many apparatus, there are many systems that can be present and that involve in many diseases, and one of them is the digestive apparatus, which is composed of many organs, many systems themselves, and that can be involved in many diseases, for example, in IBD, in inflammatory bowel diseases, but also in hepatic liver diseases. But for me, what is most important, it's in the upper respiratory and digestive tracts that we found our oral cavity that is present here. And just to resume it's that oral cavity is a part of the human body and it has to be involved in the treatment of the patients, but also in the comprehensive etiology of many diseases. In oral cavity, we can find many tissues and many organs because in this cavity, we have one teeth that represents one organ. So in our mouth, we have 28 different organs, which represent the 28 tooth, but also some gum and bone and dental alveolar ligaments. On this scheme, you can find the general anatomy of the tooth and the periodontal apparatus, which is represented here with the tooth himself. So there is many tissues that are involved in this structure. On the upper one, on the coronary part, you have the enamel and the dental. And on the root, we can find some cementum, but also the dentin. On tooth, there is also the nervous and vascular apparatus, vascular and nervous bonds that connect the tooth with the organs, with the bones and the entire body. On the same way, we can find the gum, which is a compound of the periodontal tissues. The gum is the tissue, a soft tissue that you can see in the mouth of your patients, and it recovers the alveolar bone that is the hard tissue that contains the tooth, and the link between the two is the dental alveolar ligament. These all three tissues represent the periodontal supporting tissues that are involved in periodontal diseases. As in all organs and all systems, you have the periodontal health that is composed and that is defined as a balance between the symbiotic biofilms and the host response of the patients. Periodontal diseases is characterized by the absence of tooth loss, the absence of bone loss, and the absence of periodontal loss. As you can see on the lower left photography, in patients presenting oral health, there is no calculus, no dental plaque, and no inflammations. But in many patients, there is a lack of oral hygiene, or because of the lack of the motivation of the patients, or the lack of a good technique, or lack of good materials, that cause an accumulation of dental plaque and calculus, as that can cause a periodontal loss, here represented on an X-ray radiograph, with a loss of bone that is represented just here around the tooth. Moreover, there is some periodontal risk factors that can enhance the risk of periodontal diseases progression and apparition, that is composed of smoking habits, but also with diabetes and uncontrolled diabetes. So the first pathology that we can talk about is gingivitis. Gingivitis represents an inflammation of soft tissue with a moderate inflammation, but there is also an intact bone. As you can see on the photo represented in the middle, there is some redness, there is some bleeding, there is also some pain presenting by the patients, and it's caused by the accumulation of dental plaque and dental calculus. Gingivitis patient represents gum inflammations. Its diagnosis with bleeding and probing, which is one of periodontal parameters that is calculated by periodontal specialist or dental surgeon, and it is diagnosis with BOP is more than 10%. There is no attachment loss and no bone loss. Also, what is important is that gingivitis is a reversible state. When the patients go through an oral hygiene, a good oral hygiene, patient can go back to periodontal health. The second disease that we can talk about is periodontitis. Here it is represented with an imbalance with the dysbiotic biofilms and the host response that cause periodontal loss, bone loss, and it represents a severe inflammation that can cause the loss of the tooth. So periodontitis is defined as a chronic inflammation of all of the attachment tooth loss that represent, just to remind, the gum, the periodontal ligament, and also the alveolar bone. It's characterized by an attachment loss and bone destruction caused by the inflammation, but also by a dysbiosis between os and microbiota. Here, it's an irreversible state. It means that even if the patients go with a good hygiene, all tissues that have been lost are always lost. Here we have a scheme presented by Chappell and collaborators in 2015, that represents all the history of the periodontal diseases, beginning with the clinical health and goes through gingivitis and periodontitis. You can see there is many cells, many. Here you can see the scheme that represents all the natural history of the periodontal diseases, going through clinical health, gingivitis, and periodontitis, and that involve many cells and many immune cells, but also some cytokines and mostly pro-inflammatory cytokines. In that way, in 2017, European Federation of Periodontology and American Academy of Periodontology proposed a new classifications of periodontal and peri-implant diseases and all conditions. Based on this classification, we have two dimensions. The first one is the stage of the diseases, which is represented here in this table. And what we can see is that thanks to many periodontal parameters are the clinical attachment loss, radiographic bone loss, the number of tooth loss, and some local condition, we can classify our patients between stage 1 to stage 4. What does it mean in clinical aspect? Stage 1 is an initial periodontitis, stage 2 a moderate, and stage 3 it's a severe periodontitis, whereas stage 4 it's an advanced periodontitis with many tooth that have been lost, and there is a potential loss of dentition because if the patient needs some prosthetic apparatus in stage 4, we have to extract some tooth to allow the prosthetic rehabilitations. On the second dimension, we have the grade of the periodontal diseases, which is diagnosis with some direct evidence of progression, which is represented with longitudinal data, but also some indirect evidence that is calculated with percentage of bone loss on the ages, case phenotypes. The case phenotypes is interesting because if patient presenting a heavy biofilm presence, we can think that there is slow rate of progression, and if patients didn't have many or no biofilm, it will present more a rapid rate of progression in patients. And as you can see, once again, there is some grade modifiers which are represented by the risk factors that I already mentioned, which are the smoking habits, but also the diabetes. In clinical, what does it mean? It means that in a grade A, there is slow rate of progression, and grade C represent. So in some cases, just to go back here, there is some patients that have good oral hygiene that didn't have any risk factors. They don't smoke, they don't present any diabetes, but they present some periodontal loss with bone loss, as once again presented on the radiograph here. And we can ask why patients presenting no etiologic factors and no risk factor even present some periodontal loss. As I mentioned it's because periodontal tissues and systemic tissues and apparatus are connected. There is an interrelation between periodontal diseases and systematic diseases, as represented here on this chart. There is some implication of osteoporosis on periodontal diseases, some implication and interaction between inflammatory bowel disease and mouse. Periodontal diseases are also involved in arteriosclerosis and cardiovascular diseases. There is integration between renal and pulmonary diseases, and it's a topic that is more and more studied in literature. In 2020, Graves and collaborators evaluate the percentage and the number of studies that have been published and that study the interrelation between periodontal disease and systematic ones. And the major one here presented is the cardiovascular diseases, then the nutritional and metabolic diseases, and there is few study in immune system phenomena, physiological phenomena, and lymphatic disease or others. In 2025, there is another publication by Susan and collaborators that propose the periodontal diseases as a manifestation of systemic diseases in a graphical abstract. Otherwise, in 2017, European Federation of Periodontology and American Academy of Periodontology have already proposed it in the classifications, and there is many tables that will not go so further in, but I just would like to present it to you. With the first part is the systemic disorders, which have a major impact of loss of periodontal tissues, and the first of them are genetic disorders. There is also the presence of diseases affecting oral mucosa, affecting connective tissues, affecting endocrine and metabolic disorders. There is also some acquired immunodeficiency diseases, and most of them are the neutropenia and HIV infection, inflammatory diseases. You can find here other systemic, which the major one presented is the diabetes mellitus, and also smoking habits, and at least some systemic disorders that can cause some loss of periodontal tissues represented by neoplasm and other disorders as Langerhans cell associated giant cell granuloma, etc., etc. So here, what are the intrication and the implication between periodontal diseases and hematological disorders? It has been shown that there are four major mechanisms that link the two. The first one is the increase of risk bleeding, the weakened immune systems, side effects of many therapies, and the changes in blood composition. For the first one, the increased risk of bleeding, it's almost concerns the hemophilia and platelet deficiency patients, because as you may know better than me, there is an increased risk of bleeding and an increased bleeding phenomena in these patients. In gingiva, it causes at least an increase of bleeding that can cause and miss this diagnosis of gingivitis, but it also cause an increase in irritation and a persistent inflammations. So this gingiva bleeding can represent the first symptoms of an abnormalities in clotting process that have been aware by the patients and by the clinicians, the hematologist clinicians, but also the dental surgeon clinicians that are to be aware and that to take care of these signs where they are present. The second one is the impact of the hematologic diseases on the immune systems, and it's mostly involved in leukemia and immunodeficiencies that cause an increase of susceptibility to bacterial infections. And as I mentioned it, dental plaque and dental calculus are mostly composed of bacteria and microbiome and microbiota that cause at least the development of gingivitis and periodontitis. And here it can involve the risk of development of gingivitis and periodontitis without any biofilms, but patient can present an attachment loss. The third mechanism is about the side effects of therapy, as it has been mentioned by Professor Moti. When you treat your patients, there is some chemical therapy, but also some immunosuppressors that can be proposed to patients that can cause a dry mouth, but also, once again, an hypersensitivity to infections that cause an increased risk of development of gingivitis and periodontitis. And once again, without biofilm, without dental plaque or calculus, we can be in presence of the attachment loss in patients. The last mechanisms that have been described are the changes in bone compositions in patients presenting a higher white blood cells number. We can have an increase of neutrophils and lymphocytes that can cause an increased risk of periodontal diseases in patients, but also when patients present a decrease of the number of red blood cells because of an hypochromic microcytic anemia, there is a decrease in hemoglobin, in hematocrit, and in mean corpuscular volume that can cause periodontal diseases. And there is also the risk that in red cell distribution white or erythrocyte sedimentation rate cause also an increase in periodontal diseases. At least the reduced number of platelets can cause some blood, an increase in bleeding around gingiva that can cause, once again, because of the bleeding, because of the irritation, because of the inflammation, an increased risk of periodontal diseases. All of these parameters are also implicated in the other way. It means that in an inflammation that are persistent, for example, in the presence of chronic inflammation through periodontal diseases, there is a stimulation of the bone marrow that can cause an increase of leukocytes in blood circulation, but also there is an involved in pro-inflammatory cytokines, IL-6 or CRP, that can cause, once again, an alteration of hematopoietic process that can lead to an increase or an aggravation of the hematologic treatments. All these effects of periodontal diseases on blood composition have been proposed in a publication that try to explain the anemia of inflammation and they try to mimic these diseases. They take two groups of patients, an healthy one and a periodontitis group. All patients presented no anemia. That's why they try to mimic the one. But what they explain is that in patients presenting periodontal diseases, all clinical periodontal parameters were worsened, so that is okay. They also present an increased inflammatory markers, here presented with white blood cells with CRP, ECR, or Li6. But what is more interesting is that in this periodontitis group, there is some variation in hemoglobin, in hematocrit, for example, with a statistically significant difference, but there is also some difference in metabolism marker as epidin, ferritin, and transferrin that proves that there is an impact, a real impact on periodontal diseases on blood composition. So if periodontal diseases have an impact in healthy patients, it must have a grave and typical impact on patients presenting some hematologic disorders. These disorders are for periodontal diseases distinguish in two pathologies, two main category of pathologies, the red blood cell disorders and white blood cell disorders that are resumed here. We'll not go through all these diseases, but I try to speak about the most common one. And to start, I would like to treat about sickle cell diseases, which is the most common monogenic disorders. In literature, we found that there is an increase of gingivitis and periodontitis in these patients, and because of their treatments, it represents a higher risk of gingival hypertrophy. These phenomena are caused by a repeat hemorrhagic phenomenon, some blood extravasation, but also with an increase of salivary nitric oxide present in sickle cell disease patients, and also because of elevated cytokine levels as TNF-alpha and IL-6 that is present in sickle cell disease patients that can cause an increase of periodontal diseases. Also, in these patients, there is some particular gum manifestation of the disease. First one with plasma cell gingivitis, which can be localized, as you can see here, but also which can be generalized and very severe, as you can see on the right photo, with a large hypertrophy of the gingiva that can cause some redness swelling, that can cause some pain, and that didn't allow the patients to perform a good oral hygiene. In a recent study proposed by Davidopoulos in 2021, they show that there is an increase of healthy patients in control compared to sickle cell disease patients. They present that there is more gingivitis in SCD patients compared to control, but also there is more periodontitis presenting in patients compared to control that have been involved and that have been described in literature. On the same way, in anemia, here on the first case proposed with a 13-year-old male presenting iron deficiency anemia, we can have some local manifestation of periodontal diseases, here present with a necrotic papilla, necrotic gum, with swelling, with pain in this patient, in the absence of dental plaque. In a second cases presenting in a 52-year-old female presenting aplastic anemia and treated by cyclosporine, there is a large and important hypertrophy, here presenting on the lower left photos. There is no possibility to highlight the tooth, which are completely recovered by the hypertrophy, and you can see here the panoramic, the OPT presenting of this patient with a large radiographic bone loss and the presence of migration of the tooth. Hematologic cancer are also involved in periodontal diseases, and it has been shown here in 2022 that patients presenting periodontitis, here in black, there is an increase of the incident rate of hematologic cancer in all hematologic cancer. When we go through what is more important, because it is it is involved in many cancer, we are more interested in hematologic one, and we can see here that multiple myeloma didn't present a higher risk in presence of periodontitis, but leukemia and other malignant neoplasm here present a higher risk of incidence in the presence of patients presenting periodontitis. Another study in 2024 present the present here the risk of hematologic cancer that is higher in patients presenting chronic periodontitis compared to patients not presenting a chronic periodontitis. And here they didn't evidence a higher risk in leukemia, but a major risk in lymphoma, and more interestingly, in non-Hodgkin lymphoma. What they found also that there is an increased risk in patients which are male and presenting hypertension that can be a bias in the study. Hematologic cancer presenting some periodontal diseases, but also there is some malignant manifestation in oral cavity, as you can see here on the left photo of a 65 years old male presenting lymphoma with a large bone exposition, and on the right, another 65 male patient presenting leukemia with some gingival hypertrophy that in all cases presenting some swelling, some redness, and some pain in these patients. Here, I would like to present you this publication in 2023 by Zisis and collaborators that show an exceptional case of hematologic cancer that have been diagnosed through the oral manifestations. A 26 years old male, he presents some reddish swelling, some gingival mice, an increase in bleeding on probing, and also some pseudopockets. Here you can see the presence on the photograph of gingival mices, and you can imagine the redness swelling on the upper maxillary. In OPT, there is no major problems, and blood tests are in normal range. When they look at the white blood cells, monocytes, neutrophils presenting no normal variations. There is some red blood cells that are normal, as hemogram and hematocrit. And they perform a biopsy of these gingival masses, which goes through the diagnosis of acute myeloma leukemia just because and just upon the periodontal manifestations. Here, a presence of a severe neutropenia present in a young patient, in a 13 patient with no dental plaque, no dental calculus, but there is some hypertrophic gums present in these patients. And on the radiographs, we can see that there is a large bone loss, which is represented in these patients, and that present some migration of the tooth. In 2014, Branchley and collaborators presenting an study that are interesting in the characteristic of patient presenting severe neutropenia compared to healthy ones. And we can see here that there is some blood manifestation of the severe neutropenia, as we can attempt it with an alteration in white blood cells and lymphocyte, monocytes, and neutrophil. And more interestingly, it's shown here that in severe neutropenia, there is some periodontal deep pockets, there is some clinical attachment loss, but also there is an increase in bleeding and probing in these patients with no variation in missing teeth. Also, in periodontal diagnosis, there is no difference between the patient and the total periodontitis, but what is interesting, it's in the stage, also in the severity of the periodontal diseases, here with most patients presenting severe to advanced periodontitis in severe neutropenia compared to healthy ones, and there is more moderate to weak periodontitis in healthy patients compared to severe neutropenia. I would like to focus on necrotizing periodontal diseases here, which are represented with 4 disease, a necrotizing gingivitis that only involves gum, necrotizing peritonitis that affect also alveolar bone, stomatitis that involve mucosa and basal bone, and at least NOMA, which involve facial tissues. It's a non-understood pathophysiology, but it goes once again with a description of the homeostasis between biofilm and host defenses, the presence of many bacteria as Bacteroid, Prevotella, or Porphyromonas gingivalis. They represent alcohol and smoking habits represent some risk factor as stress and low socioeconomic habits in these patients. It is involved in our classification with an highlight of patient presenting HIV or AIDS with a low CD4 counts, and these periodontal diseases, these necrotizing diseases, represent an indicator and predictor factors of HIV, a first symptom of AIDS. It can present also an oral manifestation of chemotherapy or malignant lymphoma. It can be the first symptoms of agranulocytosis or neutropenia or in von Willebrand, but for this last one, it only presents in case report. All these patients need some treatment of their periodontal diseases, and in 2020 and 2022, Sands, Herrera, and collaborators propose and scheme to treat our patients that go through 3 steps and supportive periodontal care, which represent our last steps. The first steps here, it presents with oral hygienes, and as you can imagine, it goes through dental hygienes and oral motivations. Here we can propose to our patients manual or roto-oscillative or ultrasonic toothbrush with decrease the dental plaque, decrease bleeding on probing, and decrease the periodontal pocket death that represent the major risk of periodontal diseases. Also, it is important to propose to our patients some interdontal hygiene with brushing or with flossing, which represent equal reduction in periodontal plaque and periodontal bleeding in our patients. But what is interesting for patients and what they asked us is about more mouth rinses. Fluoxetine is a major product that can be used that reduce all of our periodontal parameters, but after 14 days of use, it can cause an increase in calculus, some tooth staining, and burning sensation or mucosa erosion. That is not good for our patient and more specifically in hematologic patients. So we can propose some propolis of essential oil on long-term use that can provide some decrease of dental and periodontal parameters. Also, what is very important is the control of the risk factor, and the major one is the control of smoking cessations. As dental surgeon, but also as medical practitioner, we all can be involved in smoking cessation by proposing some nicotine substitute, but also some advice, and we can all prescribe some nicotine replacement therapies that will represent with patch, tablets, or inhalator. Also, for us, what is important is to control diabetes, most important in patient presented, so in controlled diabetes. The second part of the treatment represents the scaling and wood planing with some ultrasonic or manual instruments, and which can be involved thanks to povidone iodide irrigations. The third step is some surgical procedures. In hematologic patient, it's not always allowed because of the bleeding risk, but we can have some open flap debridement, so guided periodontal regeneration with membrane or with enamel matrix derivated, and at least we can also propose some gingivectomy in hematologic patient. What can be interesting is the use of lasers that decrease the risk of bleeding. Our last step of treatments is supportive periodontal care that is very important all along the life of the patients. Here we calculate the need of treatments of our patients thanks to the periodontal risk assessment that is proposed here on the right. And one of the dimensions of the PRR is a systemic or generalistic aspect. That means if a patient presenting some hematologic disorders, we have to immediately consider them as moderate to high risk, and we have to have a callback to the patient in 3 or in 6 months. Here, what are the effects of the periodontal treatments on blood test parameters? Once again, in patient presenting therapies, there is an improvement of the periodontal clinical parameters on inflammatory markers. Once again, here presenting in white blood cells count, but there is also some improvement of the animal-related indicators is with the IgB and is with the ICT, but also an increase of the iron metabolism parameters. Once again, I would like to focus on patient presenting smoking habits. Here in group A, patient presenting some periodontal diseases and B, presenting periodontal diseases with smoking intoxications. In all of these patients, SE and SF are involved in the risk are moderate with the presence of the smoking habits. Here with increase at the baseline, but that stay increased after 3 months of treatments, and SF that is decreased in group B with smoking habits that remains always decreased after 3 months of periodontal treatments. So what are the specificity in hematologic treatments for HERS? It's to prevent the risk of infection, prevent the risk of bleeding, and prevent the recurrence. To prevent the risk of infection, we can propose some systemic antibiotics in our patients. We can find the prescription of amoxicillin, metronidazole, and azithromycin, but azithromycin could be more interesting because of the risk of hematologic disorders caused by metronidazole. To evaluate the risk of bleeding, it has to be evaluated before the treatment, the non-surgical and the surgical treatment, thanks to blood test. But also what is very important for us for these two risks, the infection and the bleeding risk, is to consider to treat according to the therapies, and most important, to communicate with hematologist therapist on when to treat, when is the better way to treat our patients. To prevent recurrence, we can provide some oral hygiene advices, but you can also, as hematologist, provide this hygiene. So we have also to propose to our patients of supportive periodontal care, and you can propose some routine dental control to your patient. So you can propose to your patient to go through dental surgeon. Here, just to remind what's one of the cases proposed with this 42 female patient presenting some aplastic anemia and cyclosporine, only with the presence of non-surgical periodontal care and the prescription of the clindamycin here. clindamycin, sorry, here to mitigate the potential hematopoietic suppression induced by metronidazole. After 3 months of treatments, you can see here the results that there is a large decrease of the gum hypertrophy. There is no bleeding, there is no swellness, and even if there is always the presence of mass here on the posterior area, there is a large improvement of parental parameters. Here, on patient presenting some iron deficiency anemia, we can find that in group A presenting an IDA and B presenting an LC status, there is after treatment an improvement as attempt in periodontal parameters, but most interestingly here in hematologic test and in ferritin levels, we can find that there is an improvement of these parameters in all group and more interestingly in group presenting some IgA. Also, in patient presenting some leukemia before and after leukemia, we have here an improvement of the gingivitis in patient only thanks to leukemia treatment that goes through 85% to 82% that don't seem really heavy, but it is present that leukemia treatment, for example, can have an improvement of dental and periodontal parameters. So what are the take-home messages? First, we have to consider periodontal diseases as a systemic condition that can have an impact on systemic diseases and more specifically in hematologic disorders. Just to remind and to warn you about the fact that periodontal diseases can represent an early markers or indicators of hematologic disorders or of their evolutions. So it has to be really take account when you consult your patients. Treatments of periodontal diseases in hematologic patients is really intricate with systemic treatments, and at least it is very important to have a communication between hematologic and dental specialists, which is very, very important and that has been in most time forgotten because of the misunderstanding of the intrication of these two specialties. So I would like to thank you once again for your presence and I hope that I did not have been too long for this presentation.
Thank you very much, Dr. Sergar. And it was fascinating. I personally learned a lot. And actually, we have already a lot of questions, so we won't be able, for the sake of time, to take all of them, but I'll take a few. We have a question from Dr. Jose Luis Lopez Lorenzo about the value of mouth washes with bicarbonate or with chlorhexidine. What do you think?
With carbonate is one of the major questions from our patients too. In fact, it can decrease the bleeding and decrease the inflammatory aspect of gingivitis of periodontitis, but it isn't have a real effect on periodontal parameters. So we can use it in patient if they want, but it can cause also some irritation that can improve once again the risk of bleeding. So carbonate is for me not a good idea, and chlorhexidine is a better idea if it's used in mouth rinses, but we don't have to propose it in patients more than 14 days.
Excellent. Thank you very much. We have another question here about whether you can recommend a systemic drug to improve gum and dental health. So can we take a pill or an infusion or whatever?
No, on this day we did not have it. It's the same that's to toothbrush, toothpaste, or mouth rinse. It's a prevalent question in patients. What can I do without brush my tooth to didn't have periodontal diseases? There is no systemic drugs that can improve periodontal health. The only way to keep periodontal health is to brush the teeth and to brush the gums. It's the only way to keep periodontal health in patients.
Wonderful. Thank you very much. We have another question about the platelet threshold when a dentist need to perform an oral procedure. So is it 20,000, 50,000, 100,000? Are there guidelines or recommendations, or how do you handle this?
There is no recommendation, and as we have already discussed this in off, there is no many publications about the periodontal diseases treatment and the hematologic patient care. I think that it's a field that have to be investigated. So if one of you would like to study it, I think that is very, very interesting and a large topic. But unfortunately, we didn't have many recommendation guidelines or number of the reduction or the implication of periodontal diseases and hematologic disorders.
Wonderful. Thank you very much. As we conclude today's ICH webinar on periodontal disease explained to hematologists and beautifully delivered and comprehensively delivered by Dr. Johan Serger, I'd like to thank you all for your active participation and attention. I think this session has highlighted how periodontal disease is not only a localized oral problem, but a condition with systemic implications, especially in patients with hematologic malignancies and disorders who may face unique vulnerabilities. We have learned about the modern classification, the principles of evidence-based treatment, and most importantly, the critical role actually of integrating dental and hematology expertise to optimize patient outcome. A key message for me from this webinar is that periodontal health must be considered as an essential part of comprehensive hematologic care, early recognition, preventive strategies, but also coordinated management between hematologists, dentists, and the broader care team can significantly reduce complications, improve quality of life, and ultimately, of course, contribute to better survival outcomes. On behalf of the International Academy for Clinical Hematology around the globe and across the hematology field, I'd like to warmly thank our distinguished speaker, Dr. Serger, for sharing his expertise, and all of you for joining us today. Let us continue to strengthen collaborations across disciplines to ensure that patients benefit from truly holistic care. All of us at the ICH, we look forward to welcoming you to our upcoming ICH educational activities, and we may meet in person at the ICH annual meeting to be held in Paris between October 9th and October 11th. Until then, thank you very much and see you next time.